Thank you, and thank you all for participating with the CE Talk programs today. And then we hope to continue these programs in the near future, and we hope to give opportunities for clinical engineers here in China to share their experiences to global colleagues in English. And then now let's move on to the next session. We'll have Mr. Tom Judd. He is the GCEA Founders Council member, and also he's a former chair of the IFMBE CED board. And he will give a speech on the universal challenges that affect clinical engineers. Welcome.
Hey friends from China, Tom Judd here. Glad to join you today on 2022 Global Clinical Engineering Day opening. And my brief presentation is about the universal challenges that affect clinical engineers. An overview is that I'm going to talk briefly about the global clinical engineering community, both Global Clinical Engineering Alliance and Clinical Engineering Division of IFMBE, who we are, what we do, and why we do it. And then, a big deal there is that we have an urgency, particularly during the COVID times, to know and to share global best practices in our community. And then with that introduction, I'll talk about global clinical engineering status, the universal challenges for clinical engineers in China, notably. And I'll do that from several sources you see that I'll have more to say about, and then come to some conclusions. There are some things that in our relatively short time today, I'm not going to get to, but I have several other items I'll mention in the appendix. First of all, who is the global clinical engineering community? How is it led? Well, the IFMBE Clinical Engineering Board that I had the privilege of leading the previous 4 years till this past June, now led by Fabiola Martinez of Mexico, and Li Bin is on that board, as he has been in the previous 4 years, and several others. And the good news is every region as defined by WHO of the world is represented on that board. And I'm in a mentoring role with Fabiola, the new chair, and loving that opportunity to continue to work there. And then on with Dr. Yadin David, the interim president of the Global Clinical Engineering Alliance, GCEA, am on the board with him, the Founders Council, as we call it. So these two groups together work in partnership. They have different capabilities, but together are a wonderful team. And GCEA has a focus more on national societies, such as the China Society of Clinical Engineering, whereas the CED board has a focus more on individuals in those countries. The global community footprint has grown, as many of you are aware. So by this month, it's now nearly 600 collaborators from 200 countries, really covering the world. This is a busy slide, don't want to stay here too long, but what did clinical engineers around the world say were their most important issues? And one of them is capacity building. And, do we have the right people at the right places doing the right things in our field? Are we able to measure the impact of that on clinical outcomes? Are people appropriately credentialed or registered or certified to deliver their work in their various areas of the world? Are we growing to the point of being able to speak into provincial and national policy and health technologies around the world? And we also focus on continuing our work in partnership and collaboration with the World Health Organization. So those are our 5 consensus projects that the global community is working on this year. So what are the global challenges, those universal challenges? Well, they're really the projects at the bottom that I just went over: capacity building, impact measurement, credentialing, which many times in China means having the right certification, developing the ability to work in policy with the ministers of health and provincial leaders of health and your hospital leaders and so forth, and collaborating with WHO. And to get at how we're doing on that, we've got these data sources: the Body of Knowledge, Body of Practice survey, a new survey around so-called theory of change, but it's really about how do we measure our impact on downstream on clinical outcomes. We're taking advantage of the fact that during the COVID period, we've had over 60 webinars, many of them partnered with the World Health Organization, around clinical engineering, health technology management competencies, around COVID issues, directly respiratory related issues, and they've been done in multiple languages. And I know there's been a lot of work in China in your own language, of course. Then there was this, a year ago, we had our Global Clinical Engineering Congress, a virtual Congress, where we had presentations across the full breadth of clinical engineering practice in the countries, and many of those from China. And then, you know, when we ask people every year to show their sort of their best practices or their best view of their work, that's their Global CE Day country presentations. And certainly all of this applies directly to my audience today, you know, the 30+ provinces and autonomous regions there in China, as I've pictured on the right. So let's get into a little bit of what the data has shown us. We've been working hard on a capacity building framework. I call it KIC. Why do I call it KIC? Because it's called knowledge. And down the left, it's a little bit hard to see, but you'll get this presentation and be able to dive deeper into it. But for our clinical engineering practice and our universal challenge of what is a CE and how do we get recognized for who we are and what we do? Well, you know, one of the building blocks of who we are is our knowledge. A second building block is the amount of investment that's put into our field wherever we serve. And the third thing is a look at what are our resulting competencies. So to go a little bit deeper there, but not too long, is under knowledge is what's our academic training, our education, what's our ongoing training, like continuing professional development or continuing education, our training from industry, what is our level of credentialing? And then more newer in the knowledge arena is how are we learning about digital health and innovation, like being able to impact clinical workflows and deliver care more efficiently. So knowledge is one piece. Investment is, are we being invested in our province and our country from the outside? Are we doing it from the inside with the health leaders? Or outside, it might be the NGOs and industry. And then are we having mostly purchased devices or most of them donated? That's important. You know, how is the investment in clinical engineering departments going? Do you have the right facilities and test equipment, the right inventory management tools? Are you doing added value activities around quality and safety like Li Bin is doing in the Shanghai hospitals? And then in competency areas, what's the scope of your clinical engineering activities? Device maintenance and repair, clinician and healthcare team relationships. What about your local and your national society? And are you getting involved in policy, regulation, and legislation? And we've done some work on the right. I'm not going to take a lot of time, but if you might say your hospital in your province is graded in, you know, someplace on this chart, how do you move up the chart? How do you go from a lower setting to a higher setting? What are your gaps? And you can look on the right and see in knowledge and investment and competencies how you might move up in this chart, this framework. So how are we doing here? Pretty good. So I'm pleased to tell you so far on our global body of knowledge, body of practice survey, it's been out about a month. We've got over 500 responses. We don't have that as many responses as we'd like from China. And let me tell you why it would be very helpful if many more of you would take this survey. The tool is available to you through Alan from Hangzhou, or Jun Kun, and he will provide that information to you today. We've got about a dozen responses from China, but I'd love to have 100 or 500, because you would be able to take that information and then begin to see where you are and how you might grow in your particular hospital or your particular province. So I'm happy to say, look at the regions of the world there, the Americas, Africa, the Eastern Mediterranean, Middle East, North Africa, Europe, Southeast Asia, and Western Pacific, where you are, that these are countries that has already been some responses. And like I say, it's over 115 countries so far in those 500 plus responses versus 35 5 years ago when we last did this. And you know, we do have a good cross section of low middle income countries as defined by the World Bank. So what is this survey telling us? Here's some preliminary observation. Around the world, we have a young profession. 50% of practitioners around the world are under 40 years old. I think this is a good sample size, so I think this is a pretty good global number. Nearly 50% have less than 10 years clinical engineering experience. Maybe this is where you fit, so you've got an opportunity to grow and meet some of the challenges we're talking about. Around the world, 15% of our practitioners have an associate degree, 35% undergraduate, and 40% masters. And then there's, of course, more degrees than that. But Most of the people around the world need credentialing, need certification. And of course, the big thing in the last 5 years that's been growth and change in our profession is the growth of digital health clinical engineering involvement. Now, once again, we can drill down in this data, and I'm going to do that with Africa here very quickly for you as an example of what you could do province to province in China, but we need more of you to respond. So for instance, globally, 20 to 40-year-olds are 52% of the responses, and in Africa, it's 70%. So imagine if we took this kind of analysis to, many of you responded to the survey in China, and we were able to do this down to your provincial level. Imagine that. Globally, 1 to 5 years in the profession is about 25% of the profession. In Africa, it's 45%. More about degrees here. I was talking about associate and undergraduate. You see differences in China. This is more data from the survey. What are the roles and job titles? 70% CEBME globally, 15% technician, 15% professors. In Africa, it's, you know, a lesser percentage, 50% rather than 70% are clinical engineers, biomedical engineers, you know, 17% technician, 22% technologists. Global health training needed. We, you know, have more to say today about interoperability and cybersecurity and robotics. Those are the top issues around the world. Not that different in Africa. And globally, so many people say they need certification. In Africa, particularly true. And here's a lot of data. This is really too busy, but it allows you sort of by competency to break down the differences. So where are we going with this? You can use the framework and you can use this data, continue to grow your capacity. What does that mean? That means in your province, you know, there might be a bunch of public hospitals, private hospitals, others, you know, healthcare, our clinical engineers working in other healthcare roles in those settings. You can look into this data, see where you fit on the framework, see what gaps you may have and what attributes and competencies you need to focus on to grow. The data that I've just shown very at high speed here can give you that ability. Recognize there's regional differences. You know, maybe in one province, you know, you've got one need and another province a different need. So you can recognize regional differences from the survey to set your going forward strategy. Now you need to, of course, we all know to get the recognition we need, we had to develop tools for health leaders, and particularly working through WHO and its regional offices and your provincial offices. And there's so many more tools here in the past year or two to do that. You can do it through WHO training videos that show, you know, how medical equipment, particularly for COVID, is to be used and to used ideally. Those videos are in several languages. I'm pretty sure they're in Mandarin and other languages of choice for you. They are available through, there's online training that's available. So take advantage of these tools to educate your health leaders, your hospital leaders, your provincial health leaders. And then we all know that we need to work with many different kinds of stakeholders, many different kinds of influencers. And I'm talking about the universities, the academia, different doctor groups, professional groups. I'm talking about industry, various health service leaders, administrators, to drive awareness and to gain influence. And we can share findings from these surveys and help them with their health priorities, help them with their finance and funding challenges, and help them work with universities to deliver care in the areas where you live in a better way. All right, this new survey, so there's a lot of data on this body of practice, body of knowledge, body of practice survey. We've got, this is a newer survey, the Theory of Change Impact Measurement Analysis Survey. Not too many of you have taken this before. You know, the links here are, and the training on how to take this are available, but this would give us more about, so what is it that we do every day in clinical engineering? How does that, you know, maybe affect the hospital? We've got less downtime, more uptime for equipment. We've got the appropriate equipment at the appropriate times and the appropriate places. But how does that affect patient outcomes in your hospital? That's what we're trying to analyze here. We're trying to go further downstream from those activities that we do to the outputs of our work how does it affect outcomes? And then long-term, how does it affect the health of the region where you serve, the province where you serve, the hospital where you serve. So this is a little bit deeper analysis. It's going to take more time. And there's some tools here that can help you gain perspective on how impact is growing over time with clinical engineering work. And I would say, what else would I say? What's an example, Tom, of what did you mean about impact? And I mean, like affordability, I mean, access to care. I mean, how we're doing with maternal and newborn health with our medical devices making a difference. How are we doing with non-communicable, otherwise known as chronic disease? How are we doing with diabetes care in our hospital, in our region? How are we doing with heart failure and different things like that? Another area where these surveys and data is helping us is develop credentialing programs. I know I've been with Dr. David and Dr. Jim Weir and others involved in credentialing in the certification program in China. We need to do more. More of you need to get certified. We need to, grow your capability there. And this new survey, Body of Practice, Body of Knowledge, will help us there. We can do a better job of setting norms around what are clinical engineers, biomedical engineers supposed to do? What are managers and technologists and technicians? What can health leaders expect from them? There's talk about new certificates around or certifications around digital health tools. We're in the midst of developing that capability. So, and more to come on that, but here's some examples in the pictures from our colleagues in India that are certifying around biomedical maintenance and then certifying around what we might call clinical engineering, biomedical engineering. They also do that in that country, a training and educational process with exams and so forth in biomedical engineers in manufacturing and biomedical engineers in quality control, biomedical engineers in project management. So there's different models out there. How can we go deeper and wider and improve your competencies and skills in various aspects of health technology work? Nearly last but not least is we want to have the ability to speak into health leaders about health technology policy. So for example, in Rome in our Congress in 2019, Dr. Elliott Sloan from the US challenged the 1,000 people there in Rome to be more involved in telehealth policy in their countries. Wow, how important was that? When COVID came and many countries, including your own, started using more and more care delivery through telehealth. So we need to be involved in all kinds of health technology policy. And as we develop that capability, we need to look to several sources. WHO has many guidance around that. Nationally, I'm sure there's much guidance around developing health technology policy in your various provinces and in your country. We've got many case studies we can share with you from both within our community and those that we partner with. There's Ministry of Health, particularly. I mean, here's an example. Doctors and nurses do most of care delivery. We know that, and they cost the most money. They cost about half of the investment in healthcare. What if clinical engineers were more and more involved in helping reduce the technology burden on doctors and nurses so that they could take care of the patient more closely and we could take care of the technologies that they were using on the patients in care delivery? What if we had a greater role in care delivery itself? That would be something that could get into policy. It would get into workforce and investment. This is something, Japan does a lot of that, but they have a model, but there's other models around the world where they're saying, what can clinical engineers do in care delivery that relieves doctors and nurses from certain responsibilities so they can focus more on the patient? And we have colleagues that are trained for national work and policy. Dr. Sharma from the AMTZ group in India is an example. So, and Dr. David and I had the privilege of writing a perspective about this that got into the highest level of engineering in the US earlier this year. And so you can look into that reference and find more. But we think training physicians about emerging clinical engineering and health technology, getting involved in workflow, clinical workflow and workforce collaboration, like with nurses, multidisciplinary training, you know, and our various alliances. I know Dr. David is particularly tied into the leading biomedical engineering training university in your country. So how can we work together and get involved in policy? As I come to a close here, of course, working with WHO in so many ways around nomenclature and around the various tools that they have and training videos and many more tools that I don't have time to talk about. That's where we can get involved. So in conclusion, hey, the pandemic, this crisis has made our profession more highly visible globally, particularly with the World Health and the ministers of health and private system leaders. How can we take advantage using clinical engineering best practices? You know, we've presented many of those, and you know, we've got the information. We can share it with you in your language, and we can all make a difference together. So with so many tools, so many alliances available, how will you use those to grow within our profession? Thank you very much.